시청자 여러분 안녕하세요.
Ladies and gentlemen, greetings. This is Prosthodontics on Friday Night Live, which addresses different steps of prosthodontic treatment and its side effects. The grand theme of 2023 is back to the basic full denture. There's 2 lectures to go, including today's lecture. Dr. Oh Seung-hwan of Jeonju Oh Seung-hwan Healing Dental Clinic, a renowned figure in All on X, has come to discuss about All on X. Greetings. Thank you for coming here despite the rainy weather from Jeonju for Prosthodontics on Friday. The topic of the day can be a bit foreign to some. Can you explain about the details of your lecture to our audience? In the previous week, implant overdenture was discussed, and today we're going to talk about All on X, where a few number of implants are placed in residual alveolar bone. Implant-supported fixed prosthesis is provided in this way. All on X stems from the name All on 4. Rather than placing just 4 implants, placing appropriate number of implants led to the name All on X. I want to briefly address this topic. I look forward towards today's lecture even more. Those of you watching from dental side, you can participate real-time via the chat. Leave your questions and they will be answered. Through lucky draw, you'll be able to win Starbucks coffee coupons. Those of you selected as the best question will receive 3 Starbucks coffee coupons. I look forward to your keen interest and participation, and let us begin Dr. Oh's so fabulous lecture. Greetings, I'm Dr. Oh Seung-hwan. I have a private practice in Jeonju called the Oh Seung-hwan Healing Dental Clinic. I've majored in oral maxillofacial surgery. That has led to my presence here today. I'm really honored to be here. Based on my understanding, prosthodontic gurus appear on this program. I'll do my best. You're really good at prosthodontic treatment as well. So I'll do my best in providing my experience. By All on X, as mentioned, you place about 4 to 6 implants in residual bone. A few number of implants are placed. Implants are placed, and based on that, rigid fixed one-piece prosthesis is provided. This is a full arch fixed denture. This is implant-supported fixed complete denture. The advantage of All on X is that if the patient has been wearing denture for a long time, and if the patient finds it uncomfortable but has limited alveolar bone, you can provide implant-supported fixed complete denture instead of removable denture. This can be an excellent alternative in such instances. This concept was first introduced by Dr. Marlowe in early 2000s. It was first named as All on 4, and such method was introduced. In the upper, you would avoid the sinus and tilt the implant. You place the implant in the most distal area and 2 in the middle. So 4 implants in the upper. As for the lower, you would tilt the implant and place the implant in the most distal area in between mental foramen and two in the middle so that the implants can be dispersed in wide area. One piece fixed prosthesis would be provided. At least four implants would be provided for fixed partial denture. If possible, bone grafting would be avoided and long and tilted implants would be placed in residual alveolar bone. The cantilever length should be minimized, AP spread should be increased. Immediate loading is done after placement. Provisionals would be provided immediately, and a screw-type prosthesis would be provided ultimately. The benefit of all-on-4 concept is that if the patient has severe alveolar bone loss and because of the sinus or inferior alveolar nerve, implants cannot be placed by utilizing tilted implant placement and multi-abutments. By multi-abutment, I mean angled abutment. Without going through invasive surgery such as bone grafting, fixed prosthesis can be provided. The 4 to 6 implants are connected in one piece metal frame. So even with a small number of implants, it will be able to withstand occlusal forces long term. In the resorbed alveolar bone area, just as in the removable denture, flange is provided so you can provide more lip support and aesthetics can be ensured. As for the lower, implants are now placed only in between mental foramen. This allows for stability as they're less affected by bending or twisting during jaw movements, even when they're connected as one piece. There used to be a couple of disadvantages in the past. Because of these downside, all on X or all on 4 have not been widely adopted in Korea. Since when I was in university about 20 years ago, I have been performing a lot of all on 4 or all on X. And because of my experience, I've been invited today. The downside of all on 4 is that the fixed prosthesis replaces 12 teeth, so cantilever is formed in the distal molar area. If cantilever is extended, there can be mechanical issues like a fracture of prosthesis. That is why a lot of people have avoided using all on 4. Because the denture is fixated, inevitably there's foot impaction. In the beginning, when there were no design to avoid foot impaction, because of such problem, a lot of patients experienced a lot of discomforts. And in the early days, the prosthesis that goes on top was a denture teeth. When the superstructure was made of resin material, at times issues such as a fracture, dislodgement, and discoloration occurred. Because the implants were placed in a tilted manner, mechanical issues such as screw loosening, fracture, foot impaction, or peri-implantitis have occurred. Because of these reasons, all on 4 or all on X was not widely adopted. Based on our predecessors' research, the following factors serve a crucial role for all on X to succeed. More implants should be placed, but more so than that, the distribution of implants was considered more important. Another issue at hand was how to do cross-arch splinting and how to connect all the implants in rigid prosthesis. Those issues were considered most important. As shown on this image, between the most mesial implant and distal implant, and behind that, cantilever is formed. We need to minimize cantilever effect to avoid mechanical complications. In the Bronnemark days, when all-on-4 was introduced, cantilever length was considered to be okay even if it was 2 times or 2.5 times that of AP spread. When it was first introduced in Korea, framework fracture occurred frequently. The ratio, if possible, has changed 1 to 1 or 1.5 to 1 or 2 to 1 at max. These factors are very important in all-on-X treatments. This is my all-on-X strategy. It's as shown. I provide fixed partial complete denture. I minimize graft. In the lower, I use at least 4 implants, and in the upper, I try to add 2 more, using 6 implants in total. I use long and tilted implants for increasing AP spread and reducing cantilever length. I use digital method frequently. I have adopted digital dentistry about 5-6 years ago and am actively using it. Using digital dentistry for all-on-X makes things much more comfortable and you can fabricate it very easily. You use a digital surgical guide, and I tend to do immediate loading after implant placement to maintain occlusal plane and vertical dimension. If you maintain the patient's original mandible position or vertical dimension and utilize digital dentistry to include it in the workflow, it can be applied to all-on-X very easily. If possible, in the lower, I tend to do immediate loading. I do impression taking right after implant placement. If possible, in the upper, I try to do immediate loading. And I try to make sure that provisional prosthesis leads to final prosthesis. The advantage of digital dentistry is that provisional prosthesis can be easily transitioned into final prosthesis. One-piece prosthesis can be provided in screw type as shown. Let me show you a patient case. The patient first came in 2016. This is the most typical all-on-X or all-on-4 case. The patient has been using the upper and lower denture for a long time, and the ridge was severely resorbed. The patient was a female patient and was 81 years old. The patient found using denture very difficult and wanted to switch to implant prosthesis. As you can see, the lower ridge was quite resorbed. Those who have a lot of experience with full denture, or if you have a lot of technique, even if the patient has such ridge, you can provide full denture or place 2 single implants. For overdenture, implant-supported removable prosthesis can be fabricated. However, in order to provide a more stable prosthesis, I plan to place 4 implants in between mental foramen. As for the most distal implant, I try to tilt it distally as much as possible, avoiding mental foramen, and I try to position the implants as wide as possible. If you look at the analysis, the prosthesis head was positioned in between premolars. Compared with the upper, analysis was done to be able to provide 12 teeth for the upper and lower. Implant placement positions were determined and a guide was fabricated. This is surgical phase. Guide was used. Because guide may not be 100% accurate, the flap was reflected and guide was utilized in order to maintain implant for a long time. I placed the implant subcrestally after placement because it was lower. Primary stability was achieved quite easily. In order to ensure parallelness between implants, multi-unit abutments were utilized. Utilizing multi-unit abutment and taking good impression of multi-unit abutment is very important in Olonex treatment. I place the implants, connect the multi-unit abutments right after I connect the scan body on top. This is the cylinder cap for multi-unit abutment. You use scan body or cylinder cap for oral scanning, and by doing this you can get excellent impression. After taking impression, provisionals are fabricated. Provisionals are provided to the patient the day after by provisional. When we fabricated guide, VD and occlusal plane have all been adjusted so you can fabricate the screw type prosthesis very easily. Provisionals were printed out. It was fabricated just like the denture, and if you tighten the screw, you can see that there's harmony between the upper and lower prosthesis. So the patient uses this for 2, 3, or 3, 4 months, and final prosthesis would be delivered. As of late, metal frameworks such as titanium or cobalt chrome metal would be printed, or titanium could be milled as well. At the time, I printed using cobalt chrome. The framework form is made similar to teeth, and the teeth goes on top. Provisional prosthesis is fabricated in this way. X-ray was used to evaluate the preciseness of framework, and on top, zirconia teeth or resin bonding will be done on the gingival side to provide a final prosthesis. By doing this, you'll be able to get great shape, color, and aesthetics. The patient was very satisfied with the fixed prosthesis for the lower, and the patient continues to use it. For a 81-year-old female patient, it must have been hard to undergo such extensive surgery, but digital dentistry was used and minimally invasive approach was used. Only 4 implants were placed. And fixed prosthesis was provided. Then you'll be able to get better results compared with overdenture. This patient was also a female patient in her 80s. The patient had been using denture for a long time. As of 1 or 2 years, the patient found the lower prosthesis very uncomfortable. Solitary type overdenture was used. But solitary type overdenture was quite uncomfortable, so the patient wanted fixed type prosthesis, and that's why she came to my dental clinic. The patient also wanted the upper to be treated as well. You can see that there is significant atrophy in the lower ridge. The mesial implant, the contour aside, the position and direction was quite a little bit deviated, and the upper ridge was quite resorbed and significant recession had occurred. I thought long and hard how to provide implant-supported fixed prosthesis for this patient, and this was the design that I came up with. Fortunately, the patient was wearing a denture with a stable occlusal plane, and VD. It was just uncomfortable for the patient to use. I replicated the denture using digital dentistry. I did CT taking as well on CAD. Wax up was done. After wax up, following the contour of the denture, implant position was determined on CT. I used Implant Studio, which is an implant program. OSSTEM's one guide system was utilized to come up with a design. This is the shape of denture teeth, and following that, implant placement positions were determined. The straight area is where the screw hole will be formed in the anterior zone between teeth and palatal vault. In the cingulum side, screw hole was positioned. In order to maintain implant in a stable manner, the superior portion of the atrophied ridge was removed. The short implant was planned to be placed slightly deep. 4 implants, including 2 tilted implants for the posterior, were planned. I thought that AP spread would be slightly lacking if only 4 implants would be placed. In the upper posterior area, despite difficulties, 2 additional short implants were planned. I considered using socket lifting here, as shown. For the surgery, existing denture was utilized for guide design. Guide was fabricated. Existing denture was replicated, and using that, a cushion was set and a surgery was done for the upper. Layered guide was utilized, anchor pins were used, implant positions were set, flapless surgery was performed. Flapless surgery can be quite risky when you do all-on-X treatment. If necessary, you can reflect the flap slightly and make sure that the implant goes in to the bone. You can utilize the guide to get the right position for implant placement. After placement in the lower, surgery was proceeded. I decided to utilize the existing implant for the lower. Later, I found this was external type implant. In all-on-X implant treatment, because multi-unit abutments are used, I primarily use internal type implant. In the past, multi-unit abutments were used frequently for external type, but recently I have changed to internal type implants. And for the lower, following the upper denture, digital wax up was done on CAD. After determining tooth position, implant positions were set, guide was fabricated, and implants were placed. Utilizing existing tooth, the guide was fabricated and flapless surgery was done to place the implant. If necessary, you can reflect flap slightly and do bone grafting. I removed the implant that was unnecessary and provisionals were fabricated. This was for immediate loading. The provisionals, as mentioned earlier, I took impression of the multi-unit abutment and provided provisionals the following day. This was internal type TS3 implant. This was external type implant that was placed by another dental clinic. TS multi-unit abutment was used here for the external type, and here I used a type base abutment and utilized the screw type prosthesis throughout. The implant height is slightly different. In the case of all-on-X, implant height should be the same. That is very important. Tie base height and multi-unit abutment height was aligned. Impression was taken, and after that, I had the patient wear the provisional prosthesis for 3-4 months. In the upper, I was not able to do immediate loading. Prosthesis for the lower was completed first. The framework was fabricated by titanium milling in the form of Toronto Bridge, as mentioned earlier. Careful consideration was given to the screw hole position, and the framework was designed with a focus on three-dimensional hygienic form. This is a framework achieved through titanium milling. Framework was tried in. If it fits okay, then on top of it, zirconia basing is bonded. As for gingival portion, resin acrylic is used. You can see that the screw hole is positioned in the middle of the tooth. In the case of anterior area, it is slightly towards the labial side, towards the cingulum. It's very important. The framework is one piece and screw type. Screw type prosthesis was fabricated. As for the upper, as 4 to 5 months have elapsed, the second surgery was performed. At the time, multi-abutment was connected. Scan abutment or scan healing abutment was used. This is a scan healing abutment from OSSTEM. Scanning can be done very nicely, and the height is not that significant. Even when there's a slight bleeding, scanning can be done very nicely. I think OSSTEM scan healing abutment are of excellent quality, and OSSTEM's multi-abutment system is really well made. I really use it frequently. Our top management is going to love this. Impression taking method. This was the guide that was utilized to fabricate a guide. Using this, along with the scan healing abutment, merging was done, VD was set, and provisional was fabricated. Provisional was tried in, and I had the patient use it. During that period, I checked the small design and VD. I also looked at occlusal plate. Once the occlusion was stable, final prosthesis was delivered. I cut the provisional and I used the provisional along with the impression scan body of final prosthesis. Bite was taken and metal framework was milled tightly. In that state, the zirconia goes on top and on gingival portion. Resin facing is done. Color is adjusted. You can see that the prostheses are complete for the upper and lower. If you evaluate the prosthesis for the upper, there's a gingival portion using resin, and there's a teeth portion using zirconia. In the past, there was some difference. It differs from the method utilizing denture. Because the teeth continue to fracture in the past, these have been improved. The color looks much more natural. Design was made in order to prevent food impaction as much as possible. When there's alveolar bone atrophy, and when you place implants there, in the case of anterior area, it had to be placed more palatally. I was concerned about phonetics or pronunciation and invasion of tongue space. The patient had been using the denture in the upper for a long time, so the patient did not feel any discomfort in the palatally positioned implant. Fixed prostheses for the upper and lower were provided as shown. Existing implant was utilized, and it was restored as shown. Dr. Wu, that's amazing. Even young people have difficulty using digital dentistry, but you're actively using it, and I think you're a real model for the younger generation. And I would like to express my gratitude to you for using OSSTEM's One Guide system. I'm really satisfied with it. I want to ask you a question. When you utilize a digital dentistry for all on-X treatment, we need to set the right vertical dimension or centric relation and lower position. And finding the right occlusion may be at times difficult. How do you do it? Basically, as shown in the full denture concept, if VD and occlusal plane is deviated, we need to fabricate temporary denture very well. After fabricating temporary denture, if you look at occlusal plane and VD, we need to set the CRCO of the mandibular position. You need to change that denture into radiographic guide, and then after that, you need to move the radiographic guide to the CAD on the digital dentistry side. That is the most basic, efficient, and precise way to do it. You use that in the case of Dr. O. You have the patient use the temporary first. I think that is very important. As a prosthodontist, provisionals are very important before we move on to final prosthesis. I continue to fabricate provisionals up to third provisional. I look at the smile line and look at the midline and occlusal plane. Temporary provisional can be fabricated using digital dentistry. If you use conventional method, it's very difficult, but with digital dentistry, because you have the record, you can utilize it and you can also adjust it with a treatment. You can also scan the old provisional and check what's wrong immediately. If you look at the chat, there are many comments and questions. Let's take a brief look at it. Duchi, this was a topic that I was curious about, and thank you for the lecture. Smile, I'm really interested in all on X, and that's why I came. Prosthodontics on Friday, let's go. I look forward to Friday out of all the weekdays. Prosthodontics on Friday Night Live really invigorate me. Professor Joe, you look dashing as ever. I look forward to today's wonderful lecture as well. Let's go Prosthodontics on Friday seminar. Pangtae online surgery. Dr. Oh Seung-wan, Dr. Joino, you look awesome today. I think this person means that we look fabulous. Prosthodontics. I'm an avid viewer of this program, and I'm sad to hear that there's only 2 lectures left. I'll focus and relish on the meaningful information shared on the lectures. I look forward to Prosthodontics on Friday Night Live Season 4. Authority-mo, Dr. Oh, you look handsome. Yes, he definitely is. Thank you everyone for providing words of support. It's time to check out the lucky winners, and today I would like to gift Pangtae Online Surgery, who has provided compliments to both Dr. Oh and me. I want to give one more person, perhaps prosthodontics, or let's go prosthodontics on Friday. It's a little vague. I want to give another coupon to prosthodontics because I could really feel that this person is sad that there's only a couple of lectures left. Thank you for the words of encouragement once again. The program director is going to send the Starbucks coffee coupons to the 2 lucky winners. I look forward to your continued interest. As for Q&A session, we're going to address them after the lecture. Once Dr. Oh's lecture is complete, we're going to have Q&A session. Dr. Oh, please carry on.
그래서 제가 지난 대학에
I used to serve at a university, and about 10 years ago, I opened my private practice. At the university, I was in charge of a surgical section, and my peer in prosthodontics division helped me provide all-on-X prosthesis. After I opened my practice, I became in charge of surgery and prosthodontics as well. I was quite curious about the long-term prognosis. Out of 18 patients who received all-on-X at my private clinic and who have been followed up for over 5 years, I've made statistics out of it. Upon evaluation, I came up with this classification of complication. In the past, I used to provide the metal framework made of cobalt chrome along with resin teeth or denture teeth. I used to cast the metal framework. The biggest complication was a fracture of resin teeth. Fracture related to screw hole area and fracture of resin teeth in the anterior area where occlusal forces are concentrated were experienced. Fortunately, repairing the resin teeth was not difficult, but with increased number of patients, this became quite of a hassle. Also, the patient had to come back when fracture occurred, so I decided to make a change. As shown, I changed to zirconia teeth and framework shape was changed as shown, and significant improvements were achieved. However, after change, the ease of mastication typically associated with resin teeth became largely absent and was replaced with the hardness of zirconia. Zirconia is preferred because it is easy to clean and plaque control can be done effectively. Additionally, resin teeth tend to have issues with staining. Additionally, zirconia shows good bonding strength, and it's nicely maintained. Retention of prosthesis can be improved when using this option. I believe I'll continue to use zirconia teeth, but zirconia tend to be too hard and wear can occur on the prosthesis of the antagonist. I believe improvements in zirconia as material will be in line with the advancement of digital dentistry. Among acrylic, you can utilize a hard PMMA that can be milled. A lot of advancement has been made. Also, nanoceramic can be used for prosthesis as well. I believe a lot of improvements will be made. Currently, I use zirconia teeth. Another issue is food impaction in the denture flange area. So this is number 2 in terms of discomfort, and I was most concerned of it because framework is fixed and the patient cannot detach it themselves. They need to come into the clinic and remove it. As for all on four, AP gap is quite significant. In the upper area, buccal area is significantly resorbed, so you need to place the implant more palatally. In that case, ridge wrap or indentations can be formed. In these areas, food retention can occur. How can we reduce food impaction? I put in a lot of thought into it and I decided to make the design more concave, minimizing ridge wrap shape. Implant, I thought, should be placed more buccally so that it can come to the center of the teeth. Flange was positioned so that AP gap did not become too significant. We need to prevent ridge wrap form and make it convex at the border or at the flange. Such design was most important. Making it convex was most important because if you look at this patient, the ridge form, the floor was flat, and this was how it was delivered. After a couple of months, such significant food impaction occurred. Therefore, we redesigned it, making it convex. After that, the patient found it very comfortable and said that teeth cleaning became much more easier. In the case of upper, because of pronunciation, you cannot block the anterior side. I made it more convex by adjusting the palatal side in the lower. Even if there's gap between the flange, it's not going to be a major problem. The more the gap, you can allow the patient to clean it more easily. You need to make it convex and give it sufficient gap. And if you provide such flange design in lower, you will not be able to come across complications related to food impaction. At first, the patient may complain, but if you give instruction as to how to keep oral hygiene when you do follow-up, I've never experienced complaints regarding this, and some patients had food impaction in the prosthetic space. In some cases where sufficient prosthetic space was not provided in the transition zone or where the food goes up like this, the food impaction can occur. You need to do teeth brushing here. I looked at this case and since then I decided to give sufficient prosthetic space. The transition line, if it is not ideal, food impaction can occur and aesthetic issues can occur as well because border can be seen when the patient smiles. You need to provide sufficient prosthetic space in order to prevent such complications. In all on X, bone reduction is very important. You need to do it sufficiently in order to provide sufficient prosthetic space and to place implants in a stable manner. By placing implants in a stable manner, you need to place the implant fully within the bone. Bone grafts are not done. You need to do sufficient bone reduction so that implants are fully within the bone. There needs to be at least over 1 millimeters of bone on the buccal side. I want to share with you a memorable case. The patient had complication. This was a 67-year-old male patient who came in 2014. The patient did not have denture in the upper, and the patient had many discomfort. The patient was financially challenged. The patient had indication for full mouth bridge type implant prosthesis, but this was not viable. The patient wanted a few number of implants to be placed and receive stable denture. The patient also wanted fixed prosthesis. That's why All on X was planned at the time. All on X, All on 4 was designed. In order to place just 4 implants, AP spread needed to be maximized. Such AP spread was designed and the implants were tilted as much as possible. The 4 implants were distributed widely. Fixed prosthesis design was made. Guide was prepared and Immediate implant placement after extraction was performed.
그래서 발치 후 즉시 심은 다음에 템포라리를 이제 미리 만들어
Provisionals were prepared before extraction. At the time, digital dentistry was not as advanced, so holes were made on provisionals and pattern resin was used to fix it. Cylinder was fixated like this. Implants were placed. They were as much apart from each other. They were tilted, and I tried to achieve symmetry as much as possible. So sinus was not touched upon. This kind of prosthesis was made. Fortunately, because the bone resorption was not very severe, implant position was in the center of alveolar bone. If you look at the anterior zone, it's not the buccal side, but there's the hole in the incisal tip, and this led to fracture of prosthesis. Because this was resin teeth and weak, with time, fracture occurred. The advantage of it is that one-piece screw-type prosthesis could be provided, and the palate was not covered. The patient was very satisfied with it. The patient used it fine. 2 years, 3 years. Up to 4 years, there was no major problem, but after 5 years, fracture occurred. This area shows teeth fracture. I didn't think this was much of a problem, so repair was done. 7 years follow-up. Implant fracture occurred. At first, the patient came in because of screw loosening, but in the end, implant fracture occurred. I was not able to detect a screw loosening early on, so this problem resulted because all on X, they're all connected. The patient has difficulty explaining screw loosening, and if you don't take a close look on X-ray, it's difficult to find. The patient was not an easy patient to follow up as well. Because of implant fracture, implant was removed. After removal, during healing period, provisional was supported with 3 implants. I wondered whether the provisional could be maintained with just 3 implants, but that was possible. I thought about submerging the implant, but because I wanted to provide early loading, I wanted loading to be done early. A new zirconia spacing framework was provided and implant repair was done. This patient case left me with a lasting impression. All on X because of tilted implants. Many people are concerned about peri-implantitis or mechanical problems, but this was the only patient I've experienced complications with. This patient experienced implant fracture due to screw loosening, and as for the rest of my numerous implant patients, such mechanical issues did not erupt. In conclusion, among different modalities, I believe All-on-X is predictable and comfortable option for the patient. Stable results can be achieved long term. Different treatment options have been discussed under the grand theme of full denture in Prosthodontics on Friday. All-on-X is in the form of fixed denture. If you utilize digital dentistry for All-on-X, it can solve many issues that cannot be resolved with full denture. It can be a great alternative in such cases. You can provide minimally invasive treatment for the patient in this way. This is what I've prepared thus far. Thank you for the fabulous lecture. Let's take a look at the questions raised on denall site. We have a lot of questions today, so I believe we will not be able to provide in-depth response. Let's look at first responses. 옥계 소문. What are the advantages and disadvantages of utilizing all-on-X MUA fabrication method and custom method? I believe it is absolutely necessary to use multi-unit abutment because we use tilted implants. Custom abutments will not suffice. If you try to use custom abutments rather than multi-unit abutments, then you would end up with cementation-type prosthesis. There can be also deviations in fabrication. The key point in all-on-X is how well you utilize multi-unit abutment. You need to use good multi-unit abutment system. By good abutment system, it needs to be precise and you need to be able to take impression easily. It needs to be strong. When you utilize digital dentistry, there should be no issues with fracture. You need to use such multi-unit abutment system to allow for long-term use of all-on-X. I believe it is absolutely necessary to use a multi-unit abutment. Multi-unit abutments were used in the early days of Browning Mark system. I think we need to go back to such concept. DR747. This is my first time watching the program, and there's a lot of meaningful information. 1편 question. The patient has insured full denture, and after placing 2 insured implants, can I also request for insured RPD? The question is vague as to whether there are 2 insured implants and 2 general implants. That combination, in principle, is not possible. The patient will need to have teeth in order to enjoy the benefit of having 2 implants insured. Good society. When fabricating all-on-X prosthesis digitally, apart from face scanner, what else do I need? Face scanner? A lot of people use a face scanner for smile design for anterior aesthetics. As for all-on-X, facial scanners can be very meaningful in providing overall prosthesis design. I have yet to use it. Facial scanner can be of help in precisely positioning teeth. There can be no deviations. I was not able to use it because it was only recent that facial scanner became available. It's quite complicated. Soon I believe I would use it. In digital way, following the digital system, you can provide all-on-X. You need scan and CT. Drawn 70. Would 4 implants placed in the lower withstand occlusal force? Strong occlusal force from the upper. Depending on the antagonist, there can be slight differences, but I've never experienced any issues with using 4 implants in the lower. You can provide prosthesis sufficiently with 4 implants. You need to reduce cantilever. You can provide 12 teeth or, in extreme cases, 10 teeth. You need to maximize the AP spread as much as possible. In that case, 4 implants can withstand occlusal forces. Do you caution the patients about food intake? As for lower cases, I do not provide any training. As for the upper, there can be such training, but there were no problems in terms of mandible. There can be fracture in resin denture teeth. There can be mechanical issues, but it can be resolved in other ways. Captain Americano. Is there a reason why you use temporary teeth rather than temporary denture for the mandible? Will it cause more stress on the implant? As for all on X, immediate loading is extremely important in my opinion because you can establish the interarch relation, mandible position, and VD from the get-go, and it can be maintained throughout. When considering the bone quality in the mandible, immediate loading can produce sure results. I've never experienced implant failure in immediate loading cases in the mandible. Do you measure ISQ? Yes. I always check the placement torque. When placing implant, the tendency is to place it slightly deeper. It should be placed sufficiently within the bone. You need to do sufficient bone reduction and gain good primary stability. In that case, you can do immediate loading always. After immediate loading, having it be maintained up to final prosthesis is very important in all on X. Provisional teeth are better than provisional denture, yes. Can do. In the case of maxilla, are there a couple of contraindications? Perhaps because I am an oromaxillofacial surgeon, but I've never come across contraindication. I try to place as much implants as possible regardless of the position. Let me share with you a case. Can we display it on the screen? The patient has been using implant denture for a significant period, so there was a very little residual bone. If you look at the CT, there's very thin bone left. Using the program, I positioned the implant on CT. Even in extremely thin bone, I tilted the implant to place it. In the end, in the process, one implant was removed, but 4 implants were placed with wide distribution. It's been almost 10 years now. Some people say that all-on-X can be difficult or risky in the upper. You need to find bone well, and there are short implants available which can be placed when bone amount is extremely limited. You can find the right implant position if you use such implants. Let's go back to questions. Violet mint. A lot of people use partial prosthesis because oral hygiene is difficult to maintain in the case of all-on-X. Are there ways to compensate for such disadvantages? In such case, do you place 4 implants in the upper and provide bridge and partial denture in such case rather than all-on-X? This person is talking about the issue of food impaction. What's your opinion on that? I've mentioned this earlier in my lecture, but maintaining hygiene is very important in all-on-X. As mentioned, can you display this image? Between teeth and denture flange, you need to make the form convex. Hygienic form needs to be provided. In that case, the patient will not experience any discomforts and there will be no food retention. You can provide fixed denture in this way. Awesome. How much cantilever should be provided distally? This was mentioned, so we're going to move on. DM6206. When there's need for prosthesis repair, what should we do? In the case of utilizing digital dentistry, should you just make a new one or provide repair? So yes, I've made the entire thing over a couple of times. If you use digital dentistry, doing this can be made more faster. but you need to dislodge it and send it to the lab so the patient has to live without it. Yes, at times I provide temporary prosthesis for the patient to use and have it redone. However, in most cases, I do repair in the morning and provide the prosthesis in the afternoon. Yet with digital dentistry, because you can store data, you can make a new prosthesis very easily. Depending on the level of severity, you choose between the two options, can do. When you do all on X, there can be fluid retention below the base. What kind of design should be provided between abutment and prosthesis? This was already answered. Do you place more implants in anticipation of potential failure and have the implants stay in there without being used? It's a great idea. There's no such potential in the lower, but in the upper, there's a possibility of failure. Because I frequently do immediate loading in the upper as well, I try to place as much implants as possible. There's rarely failure in the anterior zone. Failure mostly occurs in premolar or posterior area if you place sufficient number of implants. At times you can have it sleep. Let's go prosthodontics on Friday. The case you've shared is Longbridge. In terms of precision, which is better, scanning and fabricating prosthesis digitally or doing conventional casting method? In the past, after casting, adjusting was essential. In the case of digital dentistry, can you skip such adjustment process? I believe so, yes. In the past, we used to do soldering and cutting. The level of precision with digital dentistry is increasing. This is one of the fundamental concerns related to digital dentistry, scanning the full arch, whether it will be precise, whether one-piece prosthesis could be provided with digital dentistry was one of the concerns. This was quite difficult. Even with analog method, you had to cut it and then connect it. What I can say right now is that in the past, using analog ways, things were very uncomfortable and difficult, but with digital dentistry, one-piece precise prosthesis can be fabricated with digital dentistry. The load on dentist can go down significantly. Even in the case of full arch, implants are positioned in the anterior zone. Arch span is not that long, so precision of oral scan is very good. Scan technique is also important. You need to have experience with scanning. You need to do scan right after surgery, and the scan techniques do require a bit of experience and learning curve. If you can do a good job scanning, also, for all on X, internal hex implant converts to external type with the use of multi-unit abutment. The accessibility becomes easier. You can provide one-piece prosthesis with this. With a precise scanning technique, you can provide one-piece prosthesis. Nice to meet you. I have yet to adopt digital dentistry in my dental clinic. In order to do all on X, can you do it in the conventional way? Yes, this is possible, but also, in order to provide digital dentistry, what kind of equipments do I need at the very least? The advantage of digital dentistry over analog method is diagnosis. You can use different diagnosis programs such as Implant Studio to make accurate diagnosis and position the implant nicely. Also, you can adjust the screw hole direction as well. In terms of diagnosis, digital dentistry is excellent. If you can use that, you can get a significant leg up. Just because you utilize digital dentistry doesn't mean you do flapless surgery all the time. Even if you use digital guide, we need to open flap to ensure that there's sufficient bone reduction. In order to accurately and precisely place the implant, you need to open flap even if you use digital guide and utilize mirror.
It's not to say that everything will become easy if you use digital dentistry. You need to do an accurate job with analog annualized digital dentistry, OSSTEM. At times, because of atrophy in the upper, you need to place implants in the palatal side. There are many complaints in that case regarding interference of tongue space. What kind of explanation do you provide to your patients? So this was one of the major concerns in the early days as well. In order to prevent invasion of tongue space, the basic is to increase vertical dimension. The patients who have been using denture for a long period, they have deviated or lowered the vertical dimension. You need to increase the vertical dimension from the beginning so that the tongue space can be lowered. Regarding invasion of tongue space, more so than the anterior zone, when the implant is positioned palatally in the premolar area, there can be many issues, including phonetics. In the anterior zone, you need to place the implants lingually because of atrophy, and I do that myself. In the beginning, the patient finds it uncomfortable, but soon adjusts to it because the patient has been using denture for a long time. The palatal area is covered in that case, but with new prosthesis, the palatal area becomes open. At first, the patient may find it uncomfortable, but with time, the complaint goes down. Mesial to the premolar area, if you place the implant slightly palatally, it's okay. Also, the material of framework is very important. In other words, even if the screw hole comes out towards the palatal side, if the material is thin and strong, it's going to be fine. These days, a lot of people use zirconia framework for all-on-X. When zirconia framework is formed around the tooth groove, it can become substantial in thickness. However, if made too thick on the palatal side, it tends to cause discomfort to the patient. If you use titanium or cobalt chrome for the framework, if you use metal, it can become very thin. If you provide a prosthesis space as such, it can become much easier. Compared with other countries, implant treatment is cheaper in Korea. Therefore, not many people use all-on-X. In terms of price, in order to get competitive edge, how long will it take? This is difficult to say, and cost is something that we need to really stick to in terms of all-on-X. When you look at the subway commercials, it's very concerning. If you go on subways in Seoul, it's very concerning. So we're going to skip through. Can do. I have a female patient who has been using denture but is experiencing immense difficulty. Yet I'm hesitating because I don't have any experience with all-on-X on the upper. The patient requires a crestal sinus lift. Before starting all-on-X treatment, what should I explain to the patient and what kind of precautions should I take during surgery, and what communication do I need to provide upon prosthesis delivery from diagnosis to end? What kind of advice would you like to give? If you do all-on-X, it's quite unlike full fixed bridge. The denture is fixed. It's different from placing many implants and providing bridge prosthesis. It's much better than overdenture system. The complication level is less, and because it's fixed prosthesis, the patients find it better. What is important is to position the implants nicely anteroposteriorly and distribute it. As mentioned earlier, diagnosis is very important in this end. You need to find the residual bone and place the implant accurately. You need to fabricate guide at open flap. We need to place the bone accurately without causing bone destruction. We need to utilize residual bone as much as possible. If you use multi-unit abutments well, the placement angle does not become a major problem because there's a 17-degree, 30-degree options, so they can come out parallel. In terms of angle, you have more freedom. You can use this option and take precise impression and provide one-piece prosthesis. What kind of communication do I need to make to the lab in order to come up with a design without food impaction? This was already discussed. It should not be ridge rim, but it should be convex. How often do you do patient follow-up? I do it every 6 months. Every 6 months you do cleaning, yes. If necessary, I tighten the area with screw loosening. I check the hygiene condition. I train about teeth brushing as well. Understood? Can do. This person has raised a lot of questions. When looking for implant placement sites, do you usually consider a standard 2 mm bone housing around the implant? 2 millimeters. In the past, 2 mm was considered safe and nice. In terms of patients' perspective, there are not that many patients with 2 mm width. I think of it as 1 mm. In the case of lower, it's 1 mm. In the upper, I tend to look for a thicker bone. What is more important is soft tissue. You need to have long vertical soft tissue height so that soft tissue sealing occurs. Sure, periodontal sealing needs to occur. You need to have sufficient biologic width. In this way, you need to place the implant. N has a question. Dr. O, you have provided fixed denture type of prosthesis with 5 implants. So what about providing fixed bridge type of prosthesis? If the interarch space is limited, you can feel tempted to provide a bridge prosthesis. Without a framework, you can make a full zirconia bridge. You need to be careful about this approach because the implant position needs to be highly accurate. This is to prevent hygiene problem and prosthesis fractures. If the position is inaccurate, bridge type of prosthesis can pose many risks. Thank you for the wonderful answers. Because of limited time, we were not able to go in deep. I would like to express my gratitude to all the participants who have raised questions and left comments. Now it's time to choose the best question. Among the people who have raised questions, I want to gift the person who has asked me a question just now. N. Yes? I find this problem very important, and I feel that this person has given a lot of thought into this topic. I want to gift this person. This person has an ID that is easy to pronounce. And congratulations. You'll receive 3 Starbucks coffee coupons on Monday via text. Don't feel too let down for not being selected as the best question. Among those who have participated in the chat, 7 people will receive coffee coupons through lucky draw. Doctor, can you give a word of advice to our peers who have stayed with us until late studying about denture and dentistry? Personally, I hope that all-on-next treatment becomes more widespread. It's a great treatment modality. In Europe, it's being done quite frequently, but in Korea, it's yet to gain popularity. Based on my experience, it produces great results. The all-on-X concept is quite different from that of Korea and other countries. I do have a concern in other countries when they provide all-on-X treatment, they remove teeth that are just fine. And then they do bone reduction and place implants to provide all-on-X system. Because of that, lower income class who find going to dentist difficult tend to resort to all-on-X treatment. I hope that does not occur in Korea. when there is a very limited residual bone, we need to find the area where there is bone and provide sufficient distribution. Then All-on-X can provide excellent results. It is a very convenient treatment option, so I hope it becomes more widespread and advanced. You truly are a pioneer in this field. Despite your busy schedule, thank you for coming here and providing a fabulous lecture. Dear viewers of Prosthodontics on Friday, today's lecture with Dr. Oh Seung-hwan was as meaningful as ever. I hope you received a lot of meaningful know-how. As for the questions unanswered today, these will be addressed via reply. In the next lecture, we're going to invite special lecturers once again. We're going to invite Professors Choi Dae-gyun and Chung Moon-gyu, who are absolute gurus in the prosthodontic field, and provide summary about full denture before we close the session. I look forward to your participation and interest, and thank you for staying with us up until late. Thank you. Thank you. Good work.